I'm Laura Mertens. I'm a urologist at the Netherlands Cancer Institute in Amsterdam, the Netherlands. Yesterday, we had a rapid fire debate together with Professor Roupret, and we discussed the optimal treatment for very high-risk non-muscle invasive bladder cancer. A very high-risk non-muscle invasive bladder cancer really is a distinct category of patients with a combination of poor risk features. And this fourth category has been added to the EU guidelines in 2021 based on a Sylvester paper showing that there is a very small subset of patients with an extremely high risk of progression. And for this reason, it is important to establish the most optimal treatment while avoiding overtreatment and weighing the risks and benefits of a cystectomy. The difference between high risk and very high risk NMIBC is the fact that very high risk NMIBC consists of a combination of many poor risk factors. For example, T1 grade 3, carcinoma in situ, and older than 70 years old, multiple tumors, large tumors. So it's a combination of poor risk factors. The difficulty in treating patients with very high-risk NMIBC is that there's hardly any data. For high-risk patients, the guidelines recommend to start with intravesical therapy. For very high-risk NMIBC, guidelines recommend to offer direct cystectomy. But there are hardly any studies focusing on this specific risk group. But the rationale is that intravesical treatment in patients with the poorest risk features leads to poor oncological outcomes, for example, due to understaging, due to high risk of progression, and because of poor survival in case of progression. On the other hand, you don't want to give all patients an upfront radical cystectomy. You have to weigh the risks and benefits of a cystectomy and avoid overtreatment as much as possible. Subtype histology, or the impact of subtype histology on non-muscle invasive bladder cancer, is largely unknown, but according to the guidelines, subtype histologies should be considered very high risk. And there are some studies suggesting a benefit of direct cystectomy for these patients. Not all patients. Patients have to be fit and have to be willing to undergo cystectomy, and that's also what the guideline says. Offer direct radical cystectomy to patients with very high risk NMIBC who are fit for cystectomy. I think it is important to realize that the fourth risk category, that very high risk NMIBC, already is a very selected subgroup of patients. So it's important to realize that we are not discussing all patients with high risk disease, but that we are really focusing on a small subset of patients with a combination of poor risk features. And hopefully future studies will guide us towards better ways to select patients for intravesical installations or cystectomy.